Well, welcome back, everyone. What I'd like to do now is to present another example for where we can use a regression model to answer the question, what's the effect of a risk factor on an outcome controlling for potential confounders? And the example I want to use is from the Framingham data set. I want to look at the effect of treating blood pressure. So one of your variables in your data set, remember, is whether a person was on treatment for hypertension. So what I'm going to be using is your Framingham data set, the one you've been using all along in this course. I'm going to limit the analysis to only people who were at risk for being treated for hypertension. So only looking at people who had previously been diagnosed with hypertension. So in your data set, there's a variable called PREVHYP1. A 1 meant that before this exam, before 1956, this individual had been diagnosed. Someone had told them that they have hypertension. And now, in 1956, some of those people were being treated for their hypertension, and some of them were not. So first of all, I'm going to run this analysis just using people who have complete data on all the variables we're going to be using, because I want to compare results from one type of analysis to another. And to do that, I want to make sure all the analyses are based on the same numbers of people, the same people. So all these analyses are going to be using people who have no missing data on any of the variables I'll be talking about in the future slides. My primary risk factor of interest is this variable BP-MEDS1. That indicates whether you were or were not being treated for hypertension at the 1956 exam. It's coded 1 if you were treated, and 0 means you were not treated. Okay, so that's the exposure of interest. The outcome is going to be the one we've been looking at all along in this course, whether you died during the 24 years of follow-up. So as a first analysis, let's just look at the crude relationship between hypertension medication, that's our exposure, and outcome of interest is mortality after 24 years of follow-up. I want to measure the crude association, the unadjusted association. And the easiest way to do that is by a 2x2 table. So here's what you would get in your data set. First of all, if you limit it to just people who had been diagnosed with hypertension before they came into their 1956 examination, there were 1,372 such people. Now it turned out 139 of them, when they showed up for their 1956 examination, indicated that they were on treatment, on medication for their high blood pressure. Someone had told them, their primary care physician, that since you have high blood pressure, I want to treat you for this. But there were 1,233 people who were not on treatment despite having high blood pressure. Now today you might think that's an extreme result. But remember, this is 1956 data. In 1956, the treatments for hypertension are not the same that we have today. And therefore, maybe the reasons or the type of person who was treated in 1956 is different from the type of person who's being treated today. But notice in these data set, we have 1,372 people, and only about 10% of them, 139 of them, are on treatment at the 1956 exam. That's our risk factor of interest. Of the people who were on treatment, the 139 people, when they were followed for 24 years, 91 of them died. The estimated risk, the cumulative incidence of death among the 139 treated individuals would be 91 over 139. Well, what about the other people, people not on hypertension medication? The 1,333 of them, 627 of them died. Their estimated risk is 627 over 1,233. I could measure a risk ratio if I want from these data, but what I want to calculate here are odds ratios, because I want to compare the result from this analysis to result from a logistic regression analysis in a minute. Remember, logistic regression models give you estimates for odds ratios, not for risk ratios. So what's the odds ratio of dying, comparing the people on medication compared to the people who are not on medication? Well, the odds of dying if you are on medication will be 91 deaths divided by 48 non-deaths. That's the odds. Roughly a little bit less than 2 is the odds of dying if you're on medication. If you weren't on medication, your odds of dying would be the 627 deaths divided by the 606 non-deaths. That's the odds of dying if you were not on blood pressure medication, a little bit bigger than 1. So the ratio of those two odds, the odds ratio is 1.83. Well, remember that number. We're going to be comparing it to something else in a minute. But what it's saying is if you're on medication, your odds of dying are almost twice as big as if you were not on medication. It seems to be implying that medication being treated for hypertension is a bad thing. It's increasing your chances of dying, your odds of dying, by almost by a factor of 2. But this is a crude association. This is not adjusting for anything. Well, from what you've been learning in STATA and what you've been learning from Marcello, you can not only estimate the effect, your best guess of the effect of hypertension medication on your odds of dying. You can build confidence intervals around it. STATA will give you confidence intervals. In this case, they go from about 1.3 up to about 2.6. But let's just remember the odds ratio itself, that 1.83. And before we rush and publish a paper to conclude that hypertension medication is bad for you, it increases your risk of dying, we as epidemiologists always have to consider alternative explanations. I've been hopping on this a few times in this course. What are the possible interpretations we can give to that odds ratio of 1.8? It may really represent the true effect of hypertension medication on your risk of dying. It might be true that hypertension medication is bad for people. It increases their odds of dying by almost 2. But before we can conclude that, we have to consider the alternative explanations that we've been stressing in these lectures. We could have a bias in our study, either a measurement bias or a selection bias. It could just be an association that's due to chance. Well, the confidence interval gives you an indication whether that's likely or not. But what I want to focus on now is this other possible explanation. The idea of there might be confounding factors here that are the reasons we're seeing roughly a 2-fold increase in odds of dying for the people being put on hypertension medication compared to the people not put on hypertension medication. It's not the medication that's doubling their odds, it's a type of person who's getting the medication that's the reason for the odds ratio being 1.8 in this example. So in our minds, here's a causal diagram. We want to know whether hypertension medication affects your risk of dying. We want to measure this middle arrow. We want to publish a result that says hypertension medication increases, decreases, it will have no effects on your outcome, dying in 24 years. But what we're afraid of is this is not a randomized trial. Those 139 people who were given medication before their 1956 exam for their hypertension, they weren't giving it because of a coin flip. They were given it because their primary care physicians thought it was the best thing to do for them. And maybe the type of person who received hypertension medication is different from the type of person who did not receive hypertension medication, different with respect to other risk factors that could cause you to get high risk or low risk of dying. So for example, it could be that the people who received hypertension medication had a different age distribution from the people who did not. And age, we know, increases your risk of dying. It could be that people who received hypertension medications were more likely to be men, and men are more likely to die than women. Or maybe they had higher blood pressure, and higher blood pressure leads to higher risk of dying. Or maybe they had diabetes. You could probably come up with a list of other potential confounding factors that might be the reason for you seeing an odds ratio of 1.8 in this study so far. That might be reasons for backdoor pathways existing to link the hypertension medication variable, the use of hypertension medication, to higher risk of dying. So these other factors are potential confounders, and your challenge is to control for them in the analysis. That's what I want to do in this example. So let's first focus on the relationships between these potential confounders and whether a person was on hypertension medication or not. Let's build a table 1 to see how comparable the 139 people who received hypertension medication were with the other people who did not receive hypertension medication. So here's a table 1 you could put into your publication. We had 139 people who received hypertension medication. We had 1,233 who did not. If we looked at the distribution of sex, male sex in saying these two groups, it turns out that 30% of the people who were in the hypertension medication group were men, compared to 47% of the people in the other group. So the two groups are not comparable with respect to sex. The comparison group, those who are not on hypertension medication, have many, many more men, percentage-wise, than the people who receive hypertension medication. And you might expect male sex brings with it higher risk of dying. And that might be a reason we're seeing the odds ratio in this data set that we're seeing. We looked at age. The average age of the people in the medication group was a little bit more than 56 years, while the average age in the other group was about 53, 54 years. So the people who received hypertension medication were older than the people who did not. In terms of their total cholesterol, 257 versus 246, again, it's higher in the people who received hypertension medication. In terms of blood pressure, either systolic or diastolic, the people who received medication have higher blood pressures than the people who did not receive medications. If we look at other factors, if we look at their body mass index and classify people as either obese or overweight, 73% of the people who received medication were overweight or obese compared to 72 in the other group. So they're pretty comparable with respect to obesity. But in terms of smoking, 35% in one group, 42% in another group. In terms of diabetes, 6% in one group, 4% in another group. In terms of prevalence of previous outcomes that now are risk factors for dying, 14% of the people who received medication for hypertension had been previously diagnosed with heart disease versus only half as much, 7%, in the comparison group. Previous strokes, 5% in the people who received hypertension medication, only 1% in those who did not. So these two groups are not comparable. The 139 people who received hypertension medication versus the 1233 who did not. We could conclude that the people who received hypertension medication were older, had higher blood pressures, either on the systolic or diastolic blood pressure, higher cholesterol values, had more diabetes, had more histories, higher histories of both coronary heart disease and stroke. On the other hand, the people who did not receive hypertension medication, they were more likely to be men and more likely to be smokers. So we have many characteristics that could be risk factors for dying that are not balanced in these two groups. We have a large potential for confounding here. And if you count the number of potential confounders I put in the previous slide, there's like 10 of them there. And 9 of them seem to be imbalanced. So how do we go about controlling for these 9 or 10 potential confounders? That's the challenge to the epidemiologist. That's what I'd like to do in the next lecture. So when we come back next time, I'm going to show you a regression model that tries to control for these factors and see if we get the same conclusion, an odds ratio of 1.8 after we adjust for those multiple confounding factors. See you then.